Thank you very much for having me. I must admit, I'd rather be in Seattle or the other way around, but hopefully next year we can meet in person again when this thing is over. As you said, my topic is about spine oncology, and I will be talking about novel implant technologies for spine oncology and reconstruction surgery. Ever since we became a national cancer center, a national spine center of excellence, the number of people we treated surgically for spinal tumors, be it primary or be it secondary, has risen incredibly. So these are the surgeries we've done in the last 11 years for these people. And we were just thinking about, next slide, that we might improve those type of surgeries. And very early we started with saying that whenever possible, we would use minimally invasive approaches. And that started in 2006 when I took over. And this is because we thought that we could minimize the wound problems that are associated with that type of surgery, especially when the patients then undergo radiation or chemotherapy. And we were using navigation for every pedicle screw we placed minimally invasive since 2011, just to be on the safe side, enhance accuracy, and then reduce radiation exposure to us. And then in 2013, we added cement augmented screws because it has become, despite being in the tumor board, having an oncologist with us, quite unpredictable how long patients live. So we wanted the construct to be at least fixed for 2 to 3 years. And if then we needed a revision, that would be different. So whenever in doubt, we use cement augmentation in these screws. And the last addition in that type of thing to improve surgery was what I will be talking about now, radiolucent implant materials, which started in 2016. In essence, these are peak carbon composite pedicle screws and rods, and they produce less artifacts on the post-op imaging. That's the main advantage, and that then obviously will help you to better control your perioperative complications. Let's say a patient deteriorates afterwards and you do an MR and you usually don't see anything. And I will show you examples of that. And then also a better oncological follow-up, which is evident in primary tumors, but it has become an issue with secondary tumors. That means metastasis too, because 25% of people will have a problem with local control and come back to you because they live longer. And that's something in focus. And the last but not least point is that you have a better radiation planning and execution. I hope I can show you this too. So these are cannulated, fenestrated carbon peak pedicle screws. You can use them with an MIS system, and they can be used for cement augmentation because they're fenestrated. The screws shanks are titanium coated, and they have a titanium tulip, and as you can see, tantal markers in the screw tips, so you can see them on a regular X-ray or a fluoro. The rods are in essence carbon peak rods, but you can also have titanium rods if you need a longer. I need to go back a bit, sorry. If you need a longer construct, this is how that looks. They are pre-bent carbon peak rods. These are the screws. The only thing that has titanium, and that is important to know, is the tulip and the set screws. This is the vertebral body replacement peak carbon. There is also a plate, a cervical plate. This is a typical example of an X-ray, how that looks like. And I don't know why this advances so fast. I'm very sorry for that. So this will be a typical case. That's a patient with a metastasis of malignant melanoma, high thoracic area, indication to do surgery. We would do that then nowadays, as I said before, with percutaneous screws that are navigated. It looks like that, and we would turn the patient around, and then he would in the end end up with a construct like that. If we were in doubt about the bone quality, we would use cement augmentation too. We don't do that in every case, especially in other thoracic cases, because there's a relevant number of cement embolisms. So the mechanical performance or the fatigue strength of these things is somewhat of a 5.5 millimeter titanium rod that you know. That means it's a bit lower than the usual 6.5 that you use. And that means, and this is an example of a patient with an aggressive hemangioblastoma, which I did already in 2017, I think, and I made a mistake. This was a heavyset male in a junctional area. I did a monosegmental, or just one below and one above, and that was a sintering. So you need usually longer constructs with that type of material because this is no screw pull-out. You can see that, right? But the rods were bending under load. This is an article in World Neurosurgery authored by Florian Ringel, my former deputy, and it summarizes the first experience that we have or had. This slide shows you that there is a big difference what type of MR you use because of the screw heads. On the right-hand side, 3 Tesla, you will have artifacts. So you need a 1.5 Tesla with artifact reduction just to have the appreciation. This is a post-op image in the 1.5 as opposed to a post-op image in the 3 Tesla. This is how it looks on a CT scan. You can see the titanium or the tantalum tip and the screw shanks here. This is an example showing you in the same patient who came in overnight and became got a 3 Tesla MRI without artifact reduction. You don't see anything. If you use a contrast enhanced artifact reduce 1.5 Tesla in the same patient, you see very good compression of the spinal cord and the metastasis. This was a recurrence. Again, this is a patient which had prior reconstruction, where you can see that he came back with a recurrence. This is already with the instrumentation in place. You see the material body replacement, and you can see very well that this is a recurrence and that the patient needs revision surgery. This is to show you how you can visualize post-op complications. Patient was operated and was paraplegic afterwards, so there was the differential diagnosis of an epidural, and this was made, but he didn't have an epidural. But we can see is an edema in the spinal cord, and he had, because that was a renal cell carcinoma and was embolized, he had a spinal cord ischemia due to embolized material going through the anterior spinal artery. So even to rule out that you have any complications, this is, I'm very sorry I'm doing this. This is very good. So the last point I want to make is about radiation dose planning. I think it's pretty obvious if you use proton beams. Usually you can't use them if you have an implant made out of titanium. And with using this type of implant, proton beam radiotherapy is feasible in all instances. We have shown that. Obviously, there's only a small number of patients that usually need proton beam therapy. This is one of them, a typical example of a chordoma, unfit for block resection, but fit for complete resection, which we did in that instance that way. And here you can see an 18-month follow-up. And I think you can clearly appreciate how well you can see that there is no residual tumor, there's no recurrent tumor, and this patient is now 3 years down the line, and he had a recurrence seeding along the retroperitoneal approach, which you could see and to take out, and then again do proton beam therapy. What is not so obvious is the regular photon radiotherapy, which you would use for patients with metastasis, if there is an advantage or not. I hope I can convince you that there is. This is a calculation of a patient with a breast cancer on L1, done by our radiotherapists. If you do a dose planning, or if a radiotherapist does a dose planning with titanium screws and rods in place, you get this type of picture with a lot of artifacts. And to be on the safe side, the standard is that you have a conventional radiotherapy, let's say 30 times 3 Xray. They usually use as their target the vertebral body plus that you resected, for example, plus all instrumented levels to be on the safe side. If you do dose planning with carbon peak and you don't have doubt where the tumor or residual tumor is, then they usually do or can do a lot more focused radiotherapy. So they can escalate the dose because they have a smaller volume. So you switch to a high dose, small volume type of radiotherapy because you still have less risk to spinal cord artery. This is already as a dosimetric impact planning published in the Journal of Applied Clinical Sciences, and the randomized controlled trial that will be starting, I think, next month, and hopefully we can prove that this is a feasible concept, which would rather be something that would change the way how these people are treated. So these are just the thing is called smart screws, and this is just the plan how we did it. Just quickly at the end, showing you this is the publication coming out, our experience of more than 200 cases now with this type in spinal metastasis. Basically, it shows you it's a pretty safe procedure, as safe as with any other titanium construct that you use. So we considered it now as a default option for all our tumors that we operate on the spine, since we can show that this is a comparable complication in the revision rate to everything else. There are some limitations at the end. This is my last slide. Carbon peak fiber rods cannot be contoured. So if you need to contour the rod, then you need to implant a titanium rod, which is available for the system, but then you lose, obviously, of course, a lot of your advantages. The screw heads still are titanium, and that's a problem probably to produce others, and they will have artifacts in regular 3 Tesla MRs. The handling properties are different to titanium screws, especially haptics are different, so you need to get used to that, even if you've done more than your share of pedicle screws. Intraop imaging, if you use a fluoro, is sometimes difficult to see that tantalum tips, and if you have a high bone density, then these screws might be sharing off. And to remember that the load bearing is equivalent to a 5.5 titanium alloy rod, so you usually need longer constructs than you would have with titanium alloy. Thank you very much.
Bernhard, that was great. I don't know if Udi, Dr. Mendel, and some of the other faculty, I know there were some questions. For me, Bernhard, this is really fascinating. And I think, you know, some of the concepts that you just brought up are very interesting. But still, I still think, and I don't know how you feel about this, but what do you do, what do you use for bone graft? And then how do you get, because, you know, especially now, everyone is so anti-carbon fiber, peak is not good, you know, it doesn't fuse. What are your strategies? And Udi, if you can get in on this as well, because I think you pointed out, you know, patients are living longer, you know, between adjuvant therapy, stereotactic radiation, chemo, all the genetic data that we're getting. You know, I have a hard time sometimes with their patients are living longer and longer. And so what do you do? What are some tricks for fusion? And then how about all this information now that we have that everyone keeps saying, you know, especially with the peak, everyone is so anti-peak right now.
Let me start with peak first. This is not really peak. I mean, this is a composite of carbon fibers and peak, and it's coated. The vertebral body replacement as well as the screw shanks with titanium, so you overcome that problem of having a peak which forms biofilm. So this is number one. Number two, I'm not aiming or no longer aiming for fusion in these patients. I'm aiming for a stable construct that holds up to I don't know how many years. And if the patient comes back eventually after 3 or 4 years and needs revision, that means he is in a category of patient that is almost on the, cured side. He will be happy, as opposed to your degenerative patient who comes back, who will be angry. This patient is living after 4 years against all odds, and he doesn't give you a hard time for doing the revision. I don't aim for fusion because I think the idea of putting in a bone graft as a vertebral body replacement in a tissue where you have radiation afterwards is an idea that is futile. So I don't aim for fusion.
So you don't even try to, you don't decorticate the facet joints, you don't put bone in
You can do that.
Yeah.
You can do that. That is an easy way to achieve that.
Yeah.
And if you have bone left, you can put it in the back. But in the front, I don't do that. But primary tumors is sometimes different. But with metastasis, I don't. And if you use cement-augmented screws, longer constructs, you need have a good vertebral body replacement in front. This usually holds up for a long time. The revisions for implant failure are less than in other pathologies.
Can you guys hear me okay?
Yeah.
I hear you.
Hey.
Yeah, I want to echo some of the points that were mentioned. I agree with the fact that we really cannot anticipate fusion on these cases. So the emphasis is really not on fusion. I do decorticate the bone and I do pack bone in there, but I hope for maybe there's going to be some fusion. And sometimes you actually get fusion in patient with metastatic disease. But you know, I come from the assumption that the likelihood of fusion is very low. Mm-hmm. So whether it's carbon fiber, PEEK, titanium, metastatic disease, you just have to rely on the construct itself and not whether the patient is going to fuse or not. I do pack it, I do put bone there, and I hope that fusion will occur, and sometimes it does. I think when it comes to these carbon fiber, these PEEK type materials, again, I think the advantage is obviously the surveillance is very good, right? There's no artifact, though there's, you know, some of the screw heads still have titaniums in them in some of the companies. And in our case, you know, when we follow with radiation, at times we follow with stereotactic radiosurgery. And in order for the radiation oncologists to do the stereotactic radiosurgery, they don't typically rely on post-op MRI because of the artifact from the titanium, and they rely on a myelogram. So one of the advantages of these other options with carbon fiber PEEK is that, you know, the imaging is so clear that could save a myelogram on these patients, and the radiation oncologists can go on and do their planning based on just the MRI and not necessarily have to do a myelogram on these patients in order to do their mapping of where exactly the radiation is going to go. So I think the emphasis on this construct is not so much on whether they're going to fuse or not, whether they have less rate of fusion as compared to titanium, but more what's coming after when it comes specifically for surveillance to see if there's any tumor recurrence, and whether you can cut out one step, which is the myelogram that needs to be done if you're planning on doing stereotactic radiosurgery.
That's a great point. The other thing I think, Bernhard, that you brought up that we often have trouble with, and I don't know, Udi, if what your thought is how do you are those screws fenestrated? Because to me, you know, the fenestrated screws now are a game changer because it cuts out 5 different steps. And then the cement hardens. How are you doing the vertebroplasty? Is it a fenestrated screw?
This goes to me?
Yeah, Bernhard.
Well, I mean, fenestrated screws are around in my country, fortunately, for a longer time, so we have a lot of experience with that. The main advantage is if you have a patient that has, let's say, multiple mets in his spine, and you have only one that is clearly, let's say, unstable, and you would bridge that one, and you put screws in the other ones and put in cement, you have the same effect that you have if you do a kyphoplasty or vertebroplasty, because it's basically a pain treatment in those, in addition to that you have a stronger construct.
Yeah, I agree. I think that fenestrated screws are game changer, Rod. I totally agree with that, especially on patients with metastatic disease in multiple levels. And you kind of start with the idea that these screws may pull out. And there's nothing more frustrating about hardware failure in patients with metastatic disease, because it's delayed the chemotherapy, it's delayed the radiation, you got to take him back to surgery. So fenestrated screws are game changers in the world of metastatic disease and patients with cancer. So I think my threshold for intraoperative trans-screw cement injection is very low. And I think now they're coming up with carbon fiber fenestrated screws, because that was one of the downsides, that they did not have the option of fenestrated screws in the carbon fiber arena. But now I think they have some available to do that too.
Great. Thanks, you guys.